decided to confess to my professional identity in this slide. I'm the MST Programme Manager in Fife, but I'm actually a clinical psychologist by profession. And I'm just mentioning it because I think I've actually had the privilege of working as a psychologist within the social work service for the last 11 years, I think. And it's enabled me to use my skills effectively for particularly complex and deserving client groups, and I think that's been a huge privilege to be able to do that, and quite a rare post as well. So the other thing is I've been quite ambitious in what I've tried to fit into this slot, mostly because the request was for an interest in the outcomes that we've been getting using MST in Fife. But I also wanted to give you a bit of background and context and tell you a bit about what MST is. So if somebody needs to give me a 5-minute warning to shut up, then please feel free to do so. Okay. So, what is MST? Very briefly, it's a community-based, time-limited, intensive intervention for antisocial behaviour in young people. The focus is on empowering parents to solve current and future problems, and that's a really core part of the model. With MST, the client is viewed as the entire ecology around the young person. That includes their family, their peer group, the school, the community they live in. And another core component of MST is a highly structured supervision process, which is a weekly group supervision process around all cases, and also builds in quality assurance support, which is essential to delivering evidence-based practice in real-world settings. Okay, I'm not going to talk in detail about this, but MST is an evidence-based practice. There's a lot of research around and been completed on MST in a variety of settings and countries. It's been going since the 1970s and originated in the States. Probably the most relevant thing to mention now is that there's been a large-scale, independent, randomised control trial ongoing down south in England at the moment. That's the START trial, and that's 9 looked at local authority NHS sites that are delivering MST to a large number of families that have been recruited predominantly from social care and youth offending services. So the data on that is due to report, the first outcomes are due to be reported next May, which will be really interesting. So basically half of those 700 families have had services as usual and half of them have had MST. So where is it being used? In Scotland, as of this week, we've got 5 MST teams, 2 in Fife, 1 in Glasgow, and Edinburgh are training, doing their 5-day orientation training for their 2 teams this week. England and Northern Ireland, there are 33 teams. There's been a very quick expansion over the last few years in the number of MST teams in the UK. Norway and the Netherlands have nationwide infrastructures for MST, which means that because of the kind of evidence base for it, they're delivering at a certain tier of service delivery across the country, and it's centrally supported. There are over 500 teams worldwide, I think, now in a variety of countries, as you can see from the slide, if you can see the slide. And obviously it's pretty widely used in the States as well. So I just wanted to take a minute to talk about why there's been such a quick expansion in MST over the last 6 years or so. There were 3 teams historically that were going, had been going since about 2000, 2001, one in London, one in Cambridgeshire and one in Belfast. But the randomised control trial then resulted in a further 9 teams being set up, and since then there's been about 16 teams in the last year for a variety of reasons. There's cross-government support for MST down south from a variety of different departments. The NICE guidelines, I don't know if anybody saw the media coverage of them about a couple of months ago now. So MST is the only named intervention for children aged 12 to 17-year-olds with serious conduct problems. So that's quite a kind of powerful message as well. There's increasing recognition of the need for a suite of evidence-based programmes for MST to be integrated into that suite of programmes and into wider service redesign for local authorities and health systems. And finally, the other reason is that there's some centralised funding for intensive interventions for children in care and on the edge of custody. And local authorities have had the choice of where they spend that funding and what their priorities are, as long as it's an evidence-based practice. And quite a large number of them have decided to use that money to invest in MST. Okay. The other thing that's been happening, there are about 13 adaptations of MST in various stages of development. These are some of the pretty well-established ones. And as areas have become experienced and successful in using MST, they've started to invest in some of those adaptations. So the ones that are being used in the UK at the moment are ones for problematic sexual behaviour, ones for serious substance misuse, ones for child abuse and neglect, which would be the one I would pick to complement our model in Fife. And also one that's the Department for Education is looking at, which is MST for Families in Transition, which is a model adapted for bringing young people back from care. Okay. So just to put it into a Scottish policy context, we've been thinking about how MST fits with GERFEC and kind of how we can make MST language and terminology fit well with GERFEC terminology. And I'm not going to talk in detail on that, but broadly, if MST is very compatible with the GERFEC model. The other thing to say is obviously it's an evidence-based programme. There's increasing thought being given to evidence-based parenting intervention programmes, such as the Incredible Years and also the Family Nurse Partnership programmes. And I was really interested to hear the talk on mentoring earlier, because there's an institution in Colorado University in the States that does a pretty rigorous evaluation for all programs that claim to prevent violence. It's called the Blueprints for Violence Prevention, and I think it's evaluated hundreds of programs. There are only 9 model programs. One of them is Family Nurse Partnerships, another one is Incredible Years, but Big Brothers Big Sisters is also one of them alongside MST. So it's really good to see that Scotland is really starting to invest in these evidence-based approaches. Okay, so I've talked about MST being an ecological model, and it basically conceptualises the child as living within a series of systems, and acknowledges that basically it's interactions between those systems and the child that is where problems can occur, strengths can occur, and where you would intervene to address difficulties. Very simplistic overview. Apologies for that. Similarly, if we're thinking about risk factors for youth antisocial behaviour or offending behaviour, then the risk factors we know are multifactorial. They come across, they occur in different systems of the young person's life. The theory with MST is that if you can identify, prioritise and address those main risk factors for that young person, then that will have the impact of improving outcomes for them. But the key to that is working through the family to improve family functioning and helping the family to support the young person to interact differently with their peer group, school and the community. Okay. Other key MST assumptions. First one is that families can live successfully without formal statutory services. And of course we haven't been collecting data on this, we should have done from the start, but would say that the majority of young people that MST have worked with in Fife have not been on supervision orders. So what we would do is try to avoid that happening, so we would deliver MSTs, which would be a diversion from the hearing system. There are probably about a third of cases where they are on orders, but we're still trying to kind of bring that tariff down by working in this way. The other assumption is that change can occur quickly, even for complex problems, when you work multisystemically. So that's a time-limited intervention for 3 to 5 months for the standard model. And the third big deal, really, is that we really are held accountable for our outcomes in MST, which was quite a kind of tough thing to adapt to, because at first it can feel like criticism, and I think that that's the big shift. But actually, what it does is make you more accountable for working out what's going on and why, and how you can fix it. Okay, I'm not going to talk a lot about this, but a lot of the interventions that are used in MST they're evidence-based, but they're pragmatic and they're action-orientated. So basically the model looks like a single practitioner working with a low caseload of 4 to 6 families at a time. You have 3 to 4 practitioners in one team. We've got 4 in each team, 5, each with a supervisor. The reason that you've got a maximum team size of 4 is that that team also have responsibility for a 24/7 on-call service in addition to their kind of full-time work. So the caseload needs to be small enough so each person that's on call knows enough about cases and calls that might come through, and that's another reason for the weekly group supervision process as well, where all cases are discussed. And then just to reiterate that all work is done in the community, the home, school, community. And it's about removing whatever barriers there are to accessing services. So not only are we accountable for outcomes, but we're accountable for engaging families. We don't get to say, I'm sure that many of you don't get to say either, they don't want the service, we'll take it away. Especially services, it's not an option. Okay, so I suppose one of the key differences maybe with other approaches is that when MST becomes involved, the request is that we take the lead for that period of time. So that there are not multiple professionals going into one household, that everybody else takes a step back, and MST is supporting that family to interact more successfully with other systems and other services, including education. But it's about having one point of contact at that point, and that's where it fits quite well with the lead professional role in GoFed. I've talked about that never-ending focus on not engaging, so it's not just seeing the family, it's being aligned with them, and that alignment is about working towards the same goals and having the same theory about what's going to help, what's going to make this better, because this is what's been maybe driving some of those difficulties in the first place. Okay, and I've talked about the continuous focus on outcomes. There are 3 core elements to MST, and I think the first one is really, really important because it's about how good an evidence-based practice you've got. If you don't have a quality assurance system, it's really, really difficult to integrate that into mainstream services. And I think there's a lot of research being done where people say, oh yes, we all do evidence-based practices, but in reality it's really difficult, especially with complex client groups where there's multiple influences on difficulties. Without a quality assurance system, it's so difficult to stay on track with what you're doing. And I think that for me, that's been the key benefit of working with MST. If we hadn't had that, I think, from the start and throughout, I think I can confess that I would have got off model by month 3 or something. But it's been really valuable that they've done. I think it's one of the programs that's done a really good job of building in quite a sophisticated quality assurance system. The other thing are the MST principles, the 9 principles, and a lot of the quality assurance is measuring to what extent the team is adhering to those principles in each case, and the MST Analytical Process. I'm not going to talk a lot about the slide because it's quite a busy one and possibly you can't see it. But basically it's a slide describing the kind of continuous arrows, black lines are input. So that's things like supervision and training, textbook manual should be on there somewhere. And then the dotted lines are kind of feedback. So if we think about the MST therapists, we tend to call them MST practitioners in Fife, their input is with the young person and their family. The output back is that they'll get a phone call once a month from our MST support office, so it's completely confidential, so the therapist never finds out which families kind of have said about them, but it's a very structured questionnaire called a therapist adherence measure. and you can collate that data, and I'll report our overall data in terms of the adherence of our therapists to the model in another slide. Therapists get their revenge because they get to rate the supervisor as well, and there's a similar measure. It's all done online. So let's left that one. I'm not going to talk a lot about the 9 principles. Let's say that they're really core to the model. This is the MST Analytical Process, and basically, or the MST do loop as they call it. The top 3 sections before the loop, the assessment stage. It's not a huge, lengthy assessment, and the expectation is that you're assessing as you're going along and using that feedback to get a better depth of understanding of what's going on and to generate new goals. So that first phase should be done within the first couple of weeks, and you should be on to orientating with the family onto the next steps. And that first stage is really about getting engagement with key participants and getting on board and having a shared view about what the issues are, what the problems are. Okay, so very quickly, first team was established in September 2009. In Fife, we had set up a second team in August 2011. Steve Alistair Gore's support was her manager at the time. The reason for that second team was demand, was that we weren't having with such a small team, we weren't having a big enough impact on demand. Okay, the goals in Fife for MST were to reduce rates of reoffending, to increase time in education and employment, and to keep young people out of care. These are very briefly, you can see on the handouts, but we're working with 11 to 17-year-olds with serious behaviour problems at home, school, and in the community, who had a caregiver willing to support them at home. At times that willingness has been a little shaky, but that's when we're really working hard on engagement. And the third criterion for Fife is that they had to be at risk of becoming accommodated as a result of their behaviours. So, our performance data, surprisingly, we've worked with 201 cases to date. It's a 50-50 split between girls and boys, which has been a bit of a surprise. We expected a much higher referral rate for boys. This is just information about our adherence scores. So this is over the whole 3.5 years since we've been running. The total scores are accumulated for all of our therapists is 0.73, and what they've done in research in MST is saying that you need to be above 0.61 to actually be delivering MST to a standard where you're likely to get good outcomes. So what we're saying is that we've still got room for improvement, but we are delivering MST so that we should be expecting some reasonable outcomes. Okay. The other aspect of it is the level of risk of young people that we've been working with. So we asked the referrer to rate the risk of becoming accommodated at the point of referral. And basically, it's the orange, the red, and the purple bits that you'd be looking on this, and they add up to about 86% of cases were rated at least high risk of becoming accommodated. So that's 50 were high risk, 25% would definitely become accommodated without MST, according to the social worker. And 11%, which we weren't expecting, which has been a sizable chunk, were already accommodated at the point of referral, which wasn't what we'd kind of really set out to do, but we have used MST to try to bring kids back home and Fife as well. And I'll report the outcomes on that if I get a chance. So at referral, 70% of your people were at home, 17% were returned home with MST support, 9% had been moved to a new caregiver, so we were working with a brand new caregiver. We're actually at 4% were adopted children, and we started to track these because they're particularly challenging cases with kind of a lot of complex issues around. We hadn't expected that. We hadn't expected MST to be used for that in Fife, for that group of young people. So we're actually going to track our outcomes for that group of cases, see if they're different from the others. Because we're not actually sure it's the best model to be using at the moment. We've had mixed success. At the point of referral, only 21% were in education, more than 75% of the week. So it's pretty low. So in terms of outcomes, I'm not going to talk about these, but this is the way the model's set up is that you record soft outcomes at case closure, and if those soft outcomes aren't looking good, then there's a good sense that your outcomes are not going to be sustained into the future. So that's why those are really important. And they're around systemic changes if you get time to have a look at them. Okay, so these are our outcomes in terms of whether young people are at home or in education or employment. And what we're doing is we're tracking outcomes up to 18 months after. And what it shows was that, if I can see my own slide, that 91% were still at home at case closure. Now that's we've had 172 through the programme and closed, so that's 91% of that 172. And if we just track down to the 18-month follow-up, we've only had 54 that have been closed to be able to follow up that 18 months afterwards. It's pretty well maintained. It has dropped, but it's 87%, so that's a good sign. And what MST's longer-term research shows that if you can make those outcomes to 18 months, then they're pretty much going to be sustained, which is why they suggest we follow them that far. Education and employment, the outcomes are not as strong, to confess that, but they're vastly improved over the intake at referral. So if you remember, it was about 21% were in school more than 75% of the time at referral. So it's gone from 21 to 73%. 18 months follow-up, it's dropped to 70%, but that outcome is being sustained as well. Okay, I'm going to talk a lot about the offender data because I'm out of time. Suffice to say, let's do a simple slide, that we counted if you just count the total number of offences in the 6 months before MST compared to the 6 months after MST, those charges dropped from 281 6 months before MST to 148 6 months post MST, which is about a 47% reduction in the total number of offences. But interestingly, that's the offending is the thing that we're not doing as well in Fife. MST services, who we have a licence to have to use MST with, they set their targets a lot higher. So basically, the target that we should be meeting is that 80% of our cases should have no further offending from the first day they get referred to us. And so we've never quite managed to. Maybe we do. That's one thing that they're challenging us to really improve on, is that offending outcome. I'm not going to talk a lot about this slide either, but just to say that what we've started to do is separate out our outcomes for young people who are at home at referral versus the ones that we brought home with MST. Because if we're going to use the model, we've got 2 weeks to work with them before we're reunited as a family, because it is a model for kids working families who are together. And actually what we're starting to find out is actually that our outcomes are very different for those two groups, that it's very difficult to bring kids home successfully. And that's why I think if people are thinking about using MST to do that, then find out about the model for families in transition, because I think it's a longer period of involvement and you get more time to set things up before you bring the young person home. So, I can't read these things, but basically what we found, that it is possible to replicate and implement evidence-based programmes. You do need really good stakeholder buy-in from all agencies. One champion is really important, but it's just not enough to achieve success with integrating evidence-based practice into everyday working. Quality assurance, I can't talk about that enough, that's very, very important as well. Resist the pressure to stretch the model, because that's what happens as well. You get gaps in service and they go, but you're really good, you can do this for this group as well, and you end up in hot, and we've done, these are all mistakes we've made basically, so we learned the hard way. It's not, I think the other caution is that MST isn't a very effective intervention process to have as a range of services. It's not a magic bullet that's going to solve a purchase placement budget overspend, for example, but it can be part of a picture as an answer to providing high quality services and moving towards addressing that. And the final point is one that Service Manager from Edinburgh is kind of very interested in, is can MST contribute to the development of systemic practice within mainstream services? Is it going to have that drip down effect, and how can we support that to happen? And I think we're seeing some signs of that in Fife, but I also think that's a really valuable aspect of having a model like this as part of your overall service. So, and I'm not going to talk about that. Thank you very much.